Hello guys, today I am going to demonstrate you anterolateral approach to tibial plateau. I think this will be the last approach in my series of tibial plateau, and if you watch all the approaches, I think now you should feel confident in approaching tibial plateau from all the sides and do a good job if you are dealing with tibial plateau fracture, which is quite common in India and I'm sure in other developing countries and developed countries as well. So today my goal is to take you in a step-by-step fashion, mainly to show you what anterolateral approach is and how to do it properly, and I will also show you submeniscal arthrotomy, how I do it, and we will plate the lateral tibial plateau as well. So I'll take you step by step as how to do this procedure in a safe and effective way. This is our theatre setup. So patient is of course supine. We are going to use tourniquet, and I'm going to make a bolster which is going to give me around 20-30 degree of flexion when I'm making my skin incision. Now, since it's the left side, I am standing on the left side. All the trolley and everything, equipment will be on the left side. The only thing that will be on the right side is my C-arm and my C-arm screen. So it's just not in the right position, but will reposition in the right place so that C-arm can come from this side. So next, I will show you the skin incision. Now Prashant is on leave today, so I don't know. Saranshu is doing the shooting. He's doing it for the first time. This is the patella. This is the anterior tibial crest. This is your Giardi's tubercle, and this is the lateral femoral condyle. So your incision, usually if it's a complicated fracture, will be, you just leave a centimeter here, then curve it across the Giardi's tubercle, and this is the joint line. I have used a C-arm. And I have used, this is my joint line. So I am just going to curve it towards the lateral femoral condyle. Now there are many approaches where when you gain experience you can do MIPO, and not all the time you need to do a submeniscal arthrotomy. But this is your usual skin incision for your anterolateral approach. So again, looking from the side, this is Giardi's tubercle. Giardi's tubercle going up. I will not go this far, but maybe up to here. So you just need to go a couple of centimeters above the joint, so as that you can elevate the flaps and you can do a submeniscal arthrotomy, and then you can inspect the joint. So next I will show you my skin incision. So skin incision is pretty straightforward, nothing spectacular, so just at an angle. When you are starting up doing your tibial plateau, I am just going to restrict my incision. I will not go down, but because you can always increase the size of skin incision if you need to. So start with a smaller incision, and if needed you can always increase the skin incision. So can you see this? So just layered skin incision. Try to be as atraumatic as possible. Okay, so this is, can I just have a self-retaining retractor please? So if I put a self-retaining retractor, this is how it looks. Now if you see here, this is your tibial tuberosity, this is your anterior tibial crest, this is your Giardi's tubercle here. Now you just need to leave a cuff of tissue here. So this is your crest. I am just going to leave a cuff of tissue so that in the end I am able to close it nicely. So this is Giardi's tubercle. That's it. That's it. So now when you come up here, so I'm just going to, this incision is also in same line as your skin incision. So this is your Giardi's tubercle. Now once you take this off, this is your tibialis anterior. Can you see this? If you just take periosteum or cob, whatever is handy, you should be able to reflect this, or sometimes even a piece of swab can do a brilliant dissection. So once you swipe it up, can you see this? If I reposition the retractor, you should be able to see the lateral aspect of the proximal tibia. So can you see this? This is the anterolateral surface. This is usually where the plate will go. Now this dissection is very easy. because all you need to do is cut the fascia and reflect this tiband, and now you are on the surface. Now the key is when you dissect here. Now the dissection here is that you need to go in the right layer so that you are able to reflect this up in one big layer. That is the first requirement. Now if you see here, can I have a Gilpey's retractor? Now if you focus here, I am through the ITB, but still I am extra capsular. So I think I have the wrong forceps. I'm just going to swap my forceps. And if you can give me a bigger tooth forceps, that will be handy. So the key is to reflect this up in a way that you stay extra capsular. So layer one thick layer here and reflect it in the front. You can use a diathermy if you want to, but you need to reflect it as one thick layer. Can you see this? This is the anterior layer. So same way, following the same principle, lift this and stay in the extracapsular layer. Same way, I will try my hand not to come here, not to come in your way. Stay and then stay extracapsular and start retracting. What it does is you will be able to do a good closure in the end. You don't necessarily need to open the joint. The key is to come in the right place. So if you stay here, I have reflected a layer in the front, and now I am reflecting a layer in the back. Can you see this? Can you see the joint? No, because I am still extra articular, and that is what, if I can have a Gilpey retractor please. So if I now place my Gilpey retractor between this anterior and posterior layer, you can see this. This is where your meniscus is. So if at all you need to do a submeniscal arthrotomy, this is the place you are going to make a vertical incision here. So now this is actually your anterolateral approach completed. Now whatever is left is to dissect this tiband right up to the head of the fibula, right on the back, and which is a very easy step. So I will just take a periosteum and I will dissect and reflect the tiband. So use something like a cob or a periosteum, and then you need to reflect this as one thick layer. Now if I think I still need to go slightly anterior just as to see my fracture. If you can see here, I have reflected all the way back. This is the tibialis anterior reflected back. This is a cuff of tissue I have left. This is extra articular dissection. We are not into the joint. So let me just go slightly more in the front, and then we shall be able to identify our fracture site. So that will be your next step. So keep going front and identify where your fracture site is. But now depending upon what fracture it is, if it is a type 3 fracture, all you need is to make a hole here and then elevate the articular surface, fill the bone graft and plate it. If it is a type 2 fracture, what I usually like is in most complex fracture is I open it like a book, and then I see the fracture, and then I elevate the articular surface, and then I will put a bone graft if needed, and then put a plate. So just let me go slightly in the front, and once I have done that, I will join you back. So far we have reflected tiband, we have reflected the ITB from Jerdis tubercle, and now I have gone all the way in the front. This is what is my usual preference, and if you see here, this is the fracture condyle. Can you see this? This is the area which is broken. So I am just going to release this slightly, and I personally like to open it like a book. So if you follow Luo classification, which I think is most important, or revisiting Skatz's classification, the recent paper, this is your split wedge fragment. So I need to put my thumb here in order to reduce. So there will be butter split on this area. So let me just reflect this area, and so that I am able to open this up more better, and then I can have an access to the fracture fragments. So just to reorient, this is the head end, this is the foot end, this is the medial side, this is the lateral side. Now if you see here, so far we have opened this fragment here. So this will give you a whole access. You are able to, if I put a self-retaining retractor in between, or some kind of, even if I put a Gilpey retractor here, I shall be able to open this up, or you can use a laminar spreader. This will give you a complete access to the fracture fragment. Here the depression is very minimal, but on many occasions you will see the articular fragment sometimes flipped, sometimes facing other way around, but this will give you full access. Now at this point you shall be able to reduce the articular surface under direct vision. So laminar spreader is a better equipment because it's not pointed. I just wanted to demonstrate that. So this way gives me a full access to the fracture fragments. Now if you see here, this is your lateral tibial condyle. This is the lateral tibial plateau. This is where your meniscus is. This is your meniscus. So if you want to do a submeniscal arthrotomy, just leave a cuff of tissue here, so at a meniscocapsular junction, so that you can repair it in the end. So I'm just going to open this up, and this will give you a direct access to the joint, and this will also give you an opportunity to reassess how the meniscus looks, whether it's damaged or not. You can see here, I have left this, I was just taking the peripheral bite. You can see here, this is meniscus is torn at meniscocapsular junction. So I'm just going to take this bite along with it, so that in the end when I tie to the plate or to the tissue, this gets repaired. So it is one example to show whenever there is a lateral tibial plateau, there is a very good chance, and if it is depressed a lot, that the meniscus is also injured. So I'm just retaking my bites. If you can see here, this is through the capsule, and I showed you the torn meniscus. If you can see here, it's torn peripherally. So I'm just going to take a bite and then bring it back. Just a second. So I'm just going to bring it back. So now if you see, if I'm pulling it now, it's pulling out the whole meniscus now. So this is also, there is a small tear area. I'm just going to change this to a different suture as well. So I'm just taking bite through the capsule. Now this is through the periphery of the meniscus. And again from periphery of meniscus onto the capsule. Now if you see here now, I am now able to retract the whole of the meniscus. And when I am going to tie that, this also will repair the tear which was at this junction. Now if you see here, the meniscus was, in fact, even there was a small bit which was torn inside. Now I have option of either repairing it or I can do a meniscectomy. So I have just tried to repair it. But now it's hard to show, but I can inspect whole of the joint here. Can I have a McDonald please? Just here, McDonald. So if I can lift it up here, I can virtually inspect. So I can see a small step there. Now this gives a through and through exposure. Through this you can elevate, through this window, through this you can satisfactorily visually inspect whether this reduction is completely done or not. So these are the purpose of these two openings. So one is to make sure that you have elevated the articular fragment, and here this window gives you an option of ensuring that everything is lifted to perfection before you think of putting the final plates. So now we have we cleaned it up, we reflected it under direct vision. The articular surface seems to be in a good position, and we have used this clamp to compress it. Now once you are happy that you have compressed it, just get an X-ray or a C-arm image just to ensure that your reduction is pretty good. Now if you see here, the height of the lateral condyle is restored, the articular congruity is restored, the fracture line is nicely compressed. Now it's entirely up to you whether you want to put a plate and buttress it, or you can put one or two raft screw in form of 6.5 and then you can put a plate on top. So I'm just going to open the cortex, and I'm just going to pass one screw so as to compress the fracture site, and I'm just going to put the plate on top. Now, the advantage of putting this screw is that once you have put this screw, it nicely compresses the fracture. You can get rid of your clamps and you will have full working space. So, I have just compressed it. It looks pretty nice. I am just going to take this off and I am going to show you how it looks on a C-arm. Now, if you see here, the height of the lateral tibial plateau is nicely restored, and this is the most important aspect. Articular congruity is important, but the most important is the height. The height of the tibial plateau must be reconstructed. If the height is reconstructed well, then everything else, the chances are you're going to have a great result. Now you have two options while repairing your ligament. I've left a cuff of tissue here. You can, if you want, you can repair it there. The other option is to pass these through the holes as you have in this plate. So once you pass this through the holes, let me pass it like this, and then you can tie it on top of the plate. So before, if at all you want to do this, you need to pass all your sutures through these holes before you think of putting the plate in situ. Now we had 4 sutures, 2 have gone through this, 1 have gone through this hole, and other has gone through this hole. Now it's just matter of repositioning the plate in the correct plane. So this looks pretty good to me. I'm just going to secure it in place, and then I'm going to check it in the C-arm to see if the height of the plate is good. Now we have checked the height. The height of the plate looks pretty good. So the first screw that I'm going to pass is the cortical screw to compress the fracture so that it buttresses the fragment nicely. That's it. Now the plate height looks pretty good. The screw length is a bit long, but I'm going to change it in the end because it's holding the place nicely reduced. Now once you have compressed it, it's just a matter of filling the rest of the holes, and you can do it whatever way you like. But I'm going to start with my subarticular raft screws, and then I'm going to fill the rest. We're just going to fill these holes. So I'm just putting another cortical screw here on the bottom, and then I'm going to replace the previous screw with a right size screw. I think it was long. That looks pretty good. Second cortex coming. Now we have passed all our screw. I think we forgot to show you how it looks. We will show you, but now the next important thing is to tie down the suture. So these are 2 front sutures. This plate has got only 3 holes, so we could pass only through 3 holes. So I'm just going to tie this knot here, and again we are going to tie this nicely. So this is one secure way of tying the knot. I think I've messed it up slightly. Just give me a second. That looks pretty good. So that's it. That's it. Now we have tied this sutures here. So meniscus is nicely repaired here. If you can see it, it's nicely stuck down. Now it's just a matter of closing this. So deep fascia, I start with one end, and we can continue in a continuous fashion so as to do an anatomical closure. So I usually start from bottom, but you can start from top. It's entirely up to you. See, you have left a cuff of tissue here. Can you see this? And it will just help you in your closure. So that's it. So just keep working it here. And let me carry forward a little bit, and then I will join you how it looks. Now the problem here is if you don't fix your plate well, and especially with these bulky plates that we are using, sometimes it's not possible to close it. However, if your dissection is good, if you can see here that even here we are able to cover the plate completely with your fascia, that will be lifted off from Gerdy's tubercle. So if you see here, it's nice. So I'm just going to run it to the top, and then I'm just going to tie it in the end. Now if you can see here, we have nicely covered everything. So whatever we cut, we have repositioned it back. And now I will just take few interrupted stitches, and then I will close the skin with the clips, and once I have closed, I will join you back. So this is our skin closed. We are just going to put a small sterile dressing. We are putting some compression bandage, but we are not going to put any plaster. This gentleman will start moving the knees from tomorrow. Now if you see the plate position, the lateral looks pretty good. The articular surface is good. Here, the articular surface is good. The height is good. This fragment was split into two. There is a small 1 millimeter step, but I think that will be absolutely fine. It's the height which is the most important thing. So we have reconstructed the height, and we don't give any plaster. This gentleman will go in ROM brace and will start moving his knee from tomorrow. So viewers, this was a demonstration of how to do anterolateral approach and lateral tibial plateau plating for a tibial plateau fracture. Now most of the tibial plateau require combined approach, especially the patients I deal with. I rarely see a straightforward tibial plateau fracture. Now I think I have covered all approaches which should make you capable in dealing with these fractures. I think the only thing that might be left is if you have an isolated type 3 isolated depression fracture, how I make a window and elevate it, and if I find a suitable case and if I have time on that day, I will make that video very soon. So I hope you enjoyed this video, and this will give you confidence in how to do an anterolateral approach and do a lateral tibial plateau plating. Now your thumbs up and your comments are quite valuable for us, because it tells our reach that where are you watching from and if there is any scope of improvement. So please give us a thumbs up, please do subscribe, and do share our channel. Thank you.